Assalamu alaikum. I am Dr. Masudur Rahman. Welcome you all to our live BAMOS webinar session. This is our 6th session today. As you know, in COVID pandemic situation, we are trying to arrange such webinars throughout the period. And thank you, the viewers, for being with us continuously, and hopefully will be with us for the next events also. Today, we'll discuss on oral cancer, a very pertinent topic to all of the maxillofacial surgeons. To discuss the topics, we'll present a couple of cases today, one on oral carcinoma tongue and another on gingivobuccal sulcus. To discuss the topic, we have our four experts who are all renowned maxillofacial surgeons of Bangladesh. And firstly, Vice President of BAMOS, Dr. Abu Muhammad Shahid, will chair the session today. He is Associate Professor of Maxillofacial Surgery Department, Dhaka Medical College. Before starting the session, I would like to introduce our panel expert today. We have Dr. S.M. Iqbal Shahid sir, who is the ex-senior consultant, Sir Solimullah Medical College and Midford Hospital. He is also the Vice President of Bangladesh Oral Cancer Society. স্যার সম্পর্কে শুধু এতটুকু বললেই একটু কম বলা হবে। বেসিক্যালি স্যার হলো আমাদের ম্যাক্সিলোফেশিয়াল সার্জারি ফিল্ড ইন বাংলাদেশে একজন পাইনিয়ার সার্জন, যারা অ্যারাউন্ড 90s এর দিকে ম্যাক্সিলোফেশিয়াল সার্জারির ইভলভ ইন বাংলাদেশ যাদের হাত ধরে হয়েছিল, অ্যালং উইথ প্রফেসর মতিউর রহমুল্লাহ স্যার, প্রফেসর রফিক আহমেদ ভিয়া স্যার অ্যান্ড ইকবাল শহীদ স্যার, our Honorable Rezaul Haq sir, they tried their best and they dreamed for maxillofacial surgery. That's why we are so many surgeons have been produced so far, and many of our young dental surgeons dream to be maxillofacial surgeons. Welcome you, sir, to the session. We have Dr. Waresuddin, Associate Professor, Maxillofacial Surgery Department, Bangladesh Shaikh Medical University. Welcome you, sir, to the session.
Thank you.
We have also Dr. Tarim Rahman, Associate Professor, Maxillofacial Surgery, Dhaka Dental College. Dr. Tarim Rahman, madam, welcome to the session. Dr. Muhammad Ali Hussain, Associate Professor of Maxillofacial Surgery, Chattogram Dental College. He is also with us. He is a young promising surgeon. Welcome you to the session.
Thank you.
Besides, two cases will be presented. One case is carcinoma tongue, will be presented by Dr. Ahsan. Dr. K.M. Ahsan Kobir, Assistant Professor, Maxillofacial Surgery, Dhaka Dental College. Welcome to the session. Another case on HCC gingivobuccal sulcus will be presented by Dr. Fazlur Abdul, Assistant Professor, Maxillofacial Surgery, Dhaka Dental College. Welcome to the session.
Thank you.
Before starting the session, I would like to request our Honorable Chairperson today, Dr. Abu Muhammad Shahid sir, to give his introductory speech. Dr. Abu Muhammad Shahid, please.
Assalamu alaikum. It's also already mentioned. It is already mentioned by our moderator, Dr. Iqbal. This is our 6th webinar session arranged by BAMOS. Today, what we are going to discuss, our two speaker, that is squamous cell carcinoma of oral cavity. It is very challenging work for managing squamous cell carcinoma in our country. Day by day, the prevalence and incidence of the disease is increasing rapidly. It's in one side, the number of patients what we receive is increased. It is our good effort to be conducted by the different disciplinary specialists. They already know us about this. We are dealing this sort of patient very efficiently. It's our very good achievement. But this achievement is not occurred very shortly. We had to go a long way to come to this goal. Already mentioned that our sir, Dr. Iqbal Shoaib sir, Motiur Rahman Mullah sir, Rafiq Ahmed sir, Professor Reza sir, they are the pioneer. For their effort and for making us in this position, they made a good job so that we can come to this position. And we also already make a very faithful and dependent maxillofacial surgeon to the other discipline. To treating these patients, we have to develop our training very efficiently so that screening of this disease is very important. Different type of pre-malignant lesions we have to search for so that a nationwide program should be taken. Though it is not taken yet, but in a small scale, some dental camps were arranged, but I think it should be widely done so that the screening program can be very efficiently and effectively made, and for this we have to work a very lot. So I request not only the maxillofacial surgeon and the young doctors, we have to train the dental surgeon who can first identify the pre-malignant and cancer lesions. So clinical examination should be a very important tool to rule out this disease, as because very differential diagnosis from squamous cell carcinoma are encountered. So you have to identify which is squamous cell carcinoma, which is non-squamous cell carcinoma. They're mimic like very disease. So we have to work a very lot. I'm not going to discuss elaborately. Now I'm going to request the speaker to deliver a speech. Thank you.
Hassan Kabir to present his case on carcinoma tongue. Dr. Hassan Kabir, please.
Respected chairperson of today's webinar, Abu Mohammad Shahid sir, my trainer at the very beginning of my training, respected panel of experts, SM Iqbal Shoaib sir, who is one of the pioneer in the field of our country, Mohammad Warisuddin sir, Associate Professor, BSMMU, and Treasurer of BAMOS. Tarin Rahman madam, one of my favorite teacher, a great academician, with a keen clinical eye, and above all, a good soul, who inspires everyone to move forward. Mohammad Ali Hussain sir, Associate Professor, Chattogram International Dental College. Respected viewers of today's webinar organized by BAMOS. Assalamu alaikum and very good evening. I am Dr. K. M. Hassan Kubir, currently working as an assistant professor in Dhaka Dental College. It's my pleasure to have the opportunity to present one of our case in front of you. We took a verbal consent from our patient regarding disseminating her photographs and relevant data for the sake of sharing knowledge. So I am going to my presentation. Mrs. Hasina Begum, 57 years old female, hailing from Gazipur, with the complaints of white patches over the right side of the tongue with burning sensation during taking food for last 2 years, soreness on the right side of the tongue for last 6 months, and occasional pain during taking food for the last 3 months. According to the patient's statement, she was reasonably well 2 years back. Then she noticed white patches over the right side of the tongue with burning sensation. Then she developed soreness on the right side of the tongue 6 months back that persists till date and gradually increasing. She also complained of occasional pain. With the above complaints, she visited local doctors and took medicine, but the problem didn't subside. With the above complaints, she came to us for better management. Past medical history. Patient was found hypertensive, controlled with medication. Drug history. Patient was taking antihypertensive drugs regularly. History of allergy. Patient wasn't allergic to any specific drugs and foods. Personal history. Patient is married and has 2 sons and a daughter. Didn't have any history of such illness in her family. Patient did not take betel leaf regularly and never smoked. On general examination, appearance is ill-looking, mental state conscious and cooperative, body built obese. Nutritional assessment, patient is well nourished. She is non-anemic, non-ectatic. Cyanosis, edema, clubbing was absent. And blood pressure was found 140 by 90 millimeter of mercury, pulse 72 beats per minute, and respiration 18 beats per minute. Temperature was 98.6 degree Fahrenheit. Systemic examination revealed normal except the cardiovascular system. Patient was found hypertensive, which is controlled by medication. So next comes for the local examination. Intraoral local examination, we found the mouth opening normal, oral hygiene was good, dorsum of the tongue was coated, missing of the right first molar teeth. No evidence of presence of any sharp tooth. And a 2 by 2 centimeter ulceration was present over the middle part of the right lateral border of the tongue. No involvement of the floor of the mouth or base of the tongue was found. Margin of the ulcer was irregular, edge was reverted, and white lesion around the lesion for about 5 millimeter, which could not be wiped off. So then we go for palpation, and the lesion was found to be tender. Edge was indurated, and the induration extends, and the induration extends beyond the edges up to 0.5 to 1 centimeter. Base indurated, and bleeding didn't bleed to touch, and fixity to the surrounding structure. The lesion was not fixed, was fixed to the deeper structure. Tooth mobility was absent. Then movement of the tongue was inspected, and almost all the movement of the tongue, like protrusion, retrusion, and side-to-side movement was intact, and the taste sensation was found. Patient can enjoy the taste. Local examination, extraoral local examination. No visible facial asymmetry was present. No visible swelling was present, and skin color was normal. Then we go for examination of neck, and we found that ipsilateral jugulo-digastric lymph node was palpable, which is more than 1 centimeter in diameter, and mobile, not fixed with underlying structure or overlying skin, non-tender and firm inconsistency. So let's go. So salient feature, Mrs. Hasina Begum, a 57 years old female, hailing from Gazipur, with the complaints of white patches over the right side of the tongue, with burning sensation during taking food for last 2 years, soreness on the right side of the tongue for last 6 months, and occasional pain during taking food for the last 3 months. Patient did not take betel leaf. She was hypertensive, controlled with medication. Blood pressure was 140 by 90 millimeter of mercury. Nutritional status was good, non-anemic, non-ectoric, and well hydrated. On intraoral local examination, dorsum of the tongue was found coated. There was missing right first molar. Sharp teeth were absent, and a 2 by 2 centimeter ulcer was found over the right side of the lateral border of the tongue, with white patches around it for about 5 millimeter that could not be wiped off. Margin of the ulcer was irregular, edge was everted, and base was indurated. Induration could be felt 1 centimeter beyond the edges and over the dorsum of the tongue close to the midline, but did not cross midline. Ulceration didn't have any discharge and did not bleed to touch. Fixed to the deeper structure. Tongue movement was normal and no visible facial asymmetry was present extraorally. On examination of the neck, one ipsilateral lymph node was found palpable, which was 1 centimeter at its highest dimension, mobile, firm, non-tender, and not fixed with underlying or overlying structures. So, based on our provision, all the data and everything, of my provisional diagnosis was, it was a case of malignant ulcer of the right lateral border of the tongue. Differential diagnosis include squamous cell carcinoma, deep fungal infection, traumatic ulcer. So to confirm the diagnosis, we suggested incisional biopsy for histopathology, and that revealed moderately differentiated squamous cell carcinoma. So to see any kind of bone involvement, we did go for an orthopentomogram, and for the staging of the disease and to see the extension of the lesion, we did magnetic resonance imaging. And to assess the fitness for anesthesia, we did complete blood count, blood grouping and cross matching, random blood sugar, HbS-Ag, anti-HCV, serum urea, serum creatinine, chest X-ray, ECG, and echocardiogram. And patient was declared fit for general anesthesia. So this is the MRI findings. This axial CT, we can see lesion which extends up to the midline, and in the MRI it give the measurement about 2.5 to 2 centimeter, and no involvement of the floor or base of the tongue was found, and one ipsilateral lymph node was found, which is 12 millimeter at its highest dimension at level 2. So based on all the data, our confirmatory diagnosis was a moderately differentiated squamous cell carcinoma involving the right lateral border of the tongue. The CT-name classification is T4A-N1MX, and stage in stage 4A. So after discussing with all our colleagues and members and with the patient. We make a treatment plan, that is wide local excision of the lesion and bilateral neck dissection, selective neck dissection from level 1 to 4 on both sides, and a reconstruction of the tongue defect with radial forearm free flap. So then this is the par-operative photographs. So the first, the skin marking for the bilateral neck dissection, and we used a modified apron incision bilaterally. And in the second photograph, this is after careful palpation of the lesion and the induration was failed, marking was done initially. You can see we did the marking with the quarter D, the middle one. There's the extension of the induration, and then we chalk out the primary lesion, and then 1 centimeter safe margin around the lesion to ensure a wide local excision. And tongue defect after the local excision. Frozen section biopsy would have been a very good option to assess the marginal clearance, but as this patient, we did a few just some 1 month and a little more back. Actually, that was like a corona pandemic situation. And the patient didn't have too many people, too many attendants, and they didn't want to go for. And as we are planning to do reconstruction by radial forearm free flap, so we planned that we will ensure enough margin, enough healthy tissue so that no lesion remains. And then we also go for the bilateral selective neck dissection, were performed on both sides. And on the right side, we both right and left side, we go for level 1 to level 4. And now only one ipsilateral lymph node was palpable, measuring about 1.2 centimeter. Our intention was curative, to prevent skip metastasis and early metastasis to the neck node occurs in case of tongue and floor of the mouth carcinomas. As you know, the tongue is a mobile organ, so we did a neck dissection on both sides. And bilateral and lymphatic drainage occurs in case of floor of the mouth. And now our lesion was not involved the floor of the mouth, but we took some extra precautions as our intention was totally curative. And harvesting of the radial forearm free flap was done from the left hand after performing the Allen's test. And the flap also included a cephalic vein, which we used as an additional drain in our practice. And this is the immediate, first one is the immediate post-operative photograph of the reconstructed tongue. And the next photograph is that reconstructed, the photograph of the tongue at 15th post-operative day. So this is post-operative histopathology, and you can see all the margins, ventral, anterior, and posterior resection margin, and superior resection margin, and deep resection margin. All the margins are clear, and all the lymph nodes were found reactive hyperplasia. No metastasis was seen in neck nodes, and alhamdulillah, this patient that was good for the patient. And depth of invasion was 0.4 centimeter. And now the patient is referred to NICRH for chemoradiotherapy. And we make a follow-up plan on, as you know, the oral cancer have higher risk of recurrence. So intensive follow-up schedule was advised to follow. So you can see the schedule. The first year we prescribed every 2 months interval, and the second year every 4 months, and third year every 6 months, and thereafter once a year. And during our follow-ups, we actually used to take a history taking, clinical examination, and orthopentamogram usually, and sometimes every in the first year at least we will go for another CT or MRI to see the any recurrence. This photograph actually is the complaints list that patient gave on her last follow-up. She said in our language like গলা চেপে থাকে, মনে হয় কিছু একটা চাপ দিয়ে ধরে রাখে, জিহ্বা গলা পর্যন্ত আটকায় রাখে, জিহ্বাটা মোটা লাগে. Actually, we try to do so many things to give the best outcome. We try to reconstruct the tissue as it is, but what God has gifted us, it is still we are not even very close to it. We are just trying, and we have a lot of roads to cross to give the patient a better outcome. I want to finish my presentation by saying the poetry of Robert Frost. The woods are lovely, dark and deep, but I have promises to keep, and miles to go before I sleep, and miles to go before I sleep. Thank you.
Thank you very much, Dr. Hassan Kabir, for presenting the case very nicely, elaborately. It seems you worked hard for both for managing the patient and for preparing your presentation also. At this point, I would like to request Dr. S.M. Iqbal Shahid sir to make a comment on his presentation. And I also like to request our Honorable sir to memorize some memories when they started oral cancer surgery in Dhaka Dental College in early 90s. So far I can remember. Sir, please, এই সুযোগটা আমরা মিস করতে চাই না, আপনাকে আমরা পেয়েছি আজকে। আপনারা যখন শুরু করেছেন,
thank you Iqbal, thank you the panel experts, thank you dear chairman. I am very happy, almost all are my student. I become nostalgic when I am in this session because I can remember the early days. Today, all of you have uttered some beautiful words to us, to our dear Professor Matiur Rahman Mullah, to me, to Rafik Ahmed Bhuiya and others, those who started the maxillofacial surgery in our country. Before that, I want to thank today's speaker. Beautifully, he has made this speech. He has given a time and this wonderful lecture he has made. I will comment on the lecture later. Before that, as the reporter has asked me to say something about maxillofacial surgery in Bangladesh, I can remember the year 1984 when we came back from just after post-graduation, me, Rafik Ahmed Bhuiya, Dr. Khandakar Altaf Hussain Moina, we came back. At that time, the indoor was established in Dhaka Dental College. It was running. After that, Professor Matiur Rahman Mullah, he came from Japan after completing his PhD. With his guidance, we have started doing oral and maxillofacial surgery in Bangladesh or in Dhaka Dental College. Those days was very hard for us. We have started from 8 o'clock in the morning and we have finished at 6 p.m. in the evening. Many shortages many things to do. There was no cooperation with the anesthesiologist. When we asked them to work for 8 hours, 9 hours, they refused. We cannot work for that time. But as you know, all these oral cancer cases or massive fracture cases, they took at least 4 to 5 hours time to reconstruct it. As the subject today, the oral cancer, all of us know that only surgery is not the answer. You have to reconstruct it. You can cut a tongue very easily, but the reconstruction is very difficult. As you take radial forearm free flap, it will take another 3 to 4 hours time. So in total, it will take 5, 6, 7 hours time. After coming back, we thought we have to establish a postgraduate course in our country. So we, the young maxillofacial surgeons, have started establishing MS in our country, and at last we were successful for establishing MS in Dhaka Dental College. I can remember today Dr. Bodiul Alam and one of our students who has sacrificed their life, and we have lost our colleague. So we can remember them. They were the pioneer of oral and maxillofacial surgery also. After that, day by day, this MS course has been established in BSMMU, and after that, many of our students have succeeded to get this degree, MS in oral and maxillofacial surgery. Today's the chairman, Mr. Shahed, Dr. Shahed, Dr. Wares, Dr. Tarin, they have all completed the MS oral and maxillofacial surgery from Dhaka Dental College. So we are proud of them. And at least at the end of our life, we could think we have tried to do something in our country. We have tried to establish the maxillofacial surgery in our country, and we are established. Nowadays, our students, they are working very nicely, and we are proud of them. So I don't want to elaborate more. I want to concentrate today's speech. Tongue cancer. This tongue cancer is one of the serious cancer in oral and maxillofacial surgery. If you can diagnose the tongue cancer very early, you can treat it very promptly and you will have a good result. But we should say, our patient, they came to us at a very late stage when the cancer is spread in a wide range. So at that time, it is very difficult for us to manage these cases. Anyway, our dental surgeons, those who are working in periphery, they should have enough knowledge how to diagnose a case, how to diagnose this oral cancer case very early stage. If you can diagnose this case in an early stage and send it to the proper place, then the treatment will be in a good condition and the patient will live a better life. As we know, what you do for a cancer patient, the end result is not very good because you are taking some part of the tissues, a big part of a tissue, so you are going to reconstruct it. But as the speaker says, it is not same as it was. So there will be some defect. So we will try how small will be the defect. Because if you cut a part of the tongue, there will be sufficient difficulties in deglutition, insufficient difficulties in speech. So you cannot overcome this in 100% as it was before. So we will try to reconstruct these things very neatly and we'll try to excise the tissues as long as it requires. So this will be the thing. I will join you again. I will talk to you, and I will request the other panelists to talk something.
Thank you, sir, for your inspirational and speech and appreciation for our works. I think your appreciation will inspire us a lot. And
Thank you.
sir rightly emphasized the early and late difference between early and late diagnosis. What is the outcome and what could happen? At this time, I would like to request Dr. Tarid Rahman to say something on etiological factor relating to development of tongue cancer as well as to the other side of the oral cavity. Because we will not limit our discussion on this case only. We will talk on other sides cancer also. So I'm requesting Dr. Tarid Rahman to say
Thank you, Dr.
something
Iqbal.
into pathological aspect.
My respected Honorable Chairman and my respected teacher, Dr. Iqbal Shul sir, who is my teacher from my undergraduate level, and the other panelists, panel expert, there are the presenters and all the viewers. Very good afternoon and Assalamu alaikum. In this case, we saw that Dr. Hassan have shown that there was a white plaque on the tongue for 2 years. That is, it was a potentially malignant lesion there. So, in this case, the potentially malignant disorder was the etiology. But in our country or in Indian subcontinent, main offending factor, habitual factor, is betel quid, tobacco, tobacco in the form of chewing and in the form and smoking, that is smokeless tobacco and smoking. But in Western countries, the main factor is alcohol consumption. Presently, human papilloma virus is considered or named as a potent positive factor of producing oral cancer. Tobacco, the etiology varies with widely in different geographical location. In developed countries, as I have mentioned, alcohol is the main cause. But in Indian subcontinent, Southeast Asia, part of China, and some part of America, the main cause is alcohol, tobacco, betel quid. Tobacco in different form using. And in this region, in these developing countries or in Southeast Asia, in our Indian subcontinent, actually it is multifactorial. Nutritional factors that widespread malnutrition is another factor for producing oral cancers. What they do, the tobacco, which contain, and the betel quid also comprise catechol, sulflime, betel sukari, betel nut. These betel nut causes oral submucous fibrosis, which is also being potentially malignant disorder, and the tobacco causes oxidative free radical they produce, and which causes genetic mutation. And actually, the micronutrients, the the antioxidant vitamins, zinc, selenium, they act as scavenger to remove these oxidative free radicals. But when there is the deficiency of these things, the pathogenesis of squamous cell carcinoma is encouraged, and they appear. In case the human papilloma virus is also a factor, potent factor here, especially nowadays in Western countries. We have shown, the study have shown that in young male who do not have any chewing habit, tobacco using habit, or alcohol consumption, they developed oral cancer, which are related to human papilloma virus. In our country, or in this subcontinent, it's also proven that human papilloma virus is also producing hair cancers. We have recently, in our department, we have done a study on human papilloma virus as a causative factor to evaluate it, and we have our sample size was 43, and we have seen that in 75% of cases for human papilloma virus, but we have grouped this patient or staged this patient, staged the intensity of presence of human papilloma virus, and considered the grade 3 cases as confirmed human papilloma virus as an etiology. We have found 14 patients, that is at 37% cases of the 43 cases. They are human papilloma virus related squamous cell carcinoma.
Hello.
The site also varies with the etiological factors. In this subcontinent, mainly buccal mucosa, retromolar triangle, gingiva, they are the main sites. So because of our notorious habit or our tobacco consumption habit here, which the betelquid or tobacco they held in the oral cavity in this region for a long time, and these are the dose dependent and they require long time to produce cancer. And in Western country, the tongue and floor of the mouth is the main site because of the alcohol they held in the floor of the mouth, and also the tongue, the site or where alcohol-related squamous cell carcinoma is more prone. As you know, I have already told that tobacco-related squamous cell carcinoma, there is a mutation of P53 gene, which is a tumor suppressor gene. For this, the cancer develops, squamous cell carcinoma. But in case of human papilloma virus, there is no mutation of the gene. The viral oncoprotein, they bind with P53 and retinoblastoma protein, which are the protein for maintaining, suppressing or maintaining the cell cycle. That is, that they are tumor suppressor protein, and thus they inactivate the tumor suppressor protein and they produce cancer. But there is the hope that they do not mutate the gene. So the prognosis and treatment sensitivity is different of human papilloma virus related squamous cell carcinoma. So in this subcontinent uh, and in our country, battlefield and tobacco in raw form is the main cause of oral squamous cell carcinoma. Whereas in Western countries, in developed countries, the alcohol is the main cause. But recently, human papilloma virus come forward to cause oral squamous cell carcinoma, especially in Western country, young population who are non-smoker or very few smoker, uh, and they, do, they also they are non-drinker. Human papillomavirus is also is a cause of squamous cell carcinoma in our country, and we have proved it by our study, but the sample size was uh, very low, very minimum, only 43%. I think we need a study to evaluate the role of human papillomavirus in as an ecological factor in this subcontinent. Pre-malignant lesions actually uh, play a very few role, insignificant role in producing oral squamous cell carcinoma in our country. As our studies, we have carried out many studies in our department, Dhaka Dental College, since our 1999 and up to 2019. Here we prove that with pre-malignant lesions are very few in our as a causative factor of oral squamous cell carcinoma. We have shown leukoplakia, where leukoplakia, lichen planus, erythroplasia, proliferative verrucous leukoplakia. These are the causes. These are the potentially malignant disorders here. In the case, Asan COVID has presented. I think it is a potentially malignant lesion. Is the etiology of oral squamous cell carcinoma here. Thank you, Dr. Iqbal. Thank you.
Thank you, madam, for your well describing the etiological aspect, especially relation with tobacco, relation with alcohol, and HPV virus, as well as you also mentioned about the pre-malignant condition. As Dr. Hassan showed the case, and he also stated in his history that the lady didn't have any habit of taking smoking or pan. So I think the pre-malignancy could be a positive factor in this particular case, and it has a very strong association. As in this picture, it shows a white patch around the lesion also. Thank you again. Now I am watching another member has joined in our panel, Dr. Ali Hussein Talukdar. Welcome you. He will ask a question later. Dr. Ali Hussein, welcome you to the session. He is the lecturer in Shohid Sohrawardi Medical College. Now I would like to request Dr. Warisuddin to say something on the topic described presented today, and particularly if he emphasized on how to assess the case, particularly this case and as well as other cases of the tongue cancer, how to assess and make plan for management aspect. Dr. Warasuddin sir, please.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Iqbal, and thank you, my respected teacher and mentor, Dr. Shahid Iqbal sir, my friend Dr. Tarim Rahman, and presenter Hassan Kabir, and all the experts and viewers. I am being a little bit nostalgic by hearing the lecture of my favorite teacher, Dr. Iqbal Shahid. As I was the first MSc student in Bangladesh, and Dr. Iqbal Shahid and other teachers, Dr. Mohiddin sir, Motirahman Mullah sir, Raja sir, among other sir, was with us, and they did a lot. Really, they did a lot for us as the initial stage of master's course, and they try to do many things for us. They provided us to do training, higher training in Australia. Regarding the case presentation, Dr. Hassan Kabir presented the case nicely with well documentation and well presentation, and he did a surgery very nicely and very minutely. I do appreciate him and thanks for his nice presentation. Regarding the assessment of the tongue cancer, I do suggest and I do say that clinical examination and history is very important. As Dr. Taring said, that mutation and gene mutation is one of the cause, and HPV virus is one of the cause. That's why family history is very important. Family history and genetic history is important, as because they had a study in decadential causes among 43 patients, 37% or 36% of them were HPV virus positive. Isn't? That's why this history also is important, very important. And assessment, regarding the assessment in case of tongue cancer, as because it's a very, I think that it is not a large case. It is not a big case, but sometimes tongue cancer may involve the floor of the tongue, floor of the mouth, and base of the tongue. Even it extends into the pharyngeal part also. That's why laryngoscopy or the fiber optic examination is also important in clinical for clinical assessment. Fiber optic examination also important. And in case of large case, that is severe case, both MRI and CT scan is also important, as because we have to assess the bony condition, that is mandible, whether the bone is involved and how much the bone is involved, whether it is involved the cortex or involved the marrow, or totally bone is destructed. That's why for assessment only the MRI is not sufficient for that purpose. CT scan also important, and contrast CT is very important. Contrast CT also important, bony window important, and assessment of the neck, as I observed that the presenter mentioned that they did the bilateral neck dissection. I don't know whether they did it. I have little bit query regarding the bilateral, in this case regarding the bilateral neck dissection, as because the scenario is not crossing the midline, and also is not involved the floor of the mouth, and no lymphatic involvement of the opposite side. That's why a little bit query, but he mentioned that for the better for the it's a extra care. For extra care, he did the bilateral neck dissection. That can be. And regarding the further assessment, nerve involvement should be assessed before operation, as because you have to inform the patient whether the nerve is involved or not. If the hypoglossal nerve is involved, you have to counseling the patient regarding postoperative complication and other cranial nerves involvement. Also, you have to counseling with the patient and patient attendant regarding the nerve involvement, and also regarding the bone involvement and type of resection, whether you will do the marginal resection, marginal mandibulectomy, or hemimandibulectomy, or other types of treatment. And you have to counseling the regarding the counseling, you have to assess very muchly whether what type of reconstruction you will do, and assessment of the reconstruction site also important. Reconstruction of the radial forearm, whether the patient is hand is functioning or not, that are to assess, and other reconstruction site also should be assessed. And this is the important thing that you have to everybody should assess during oral cancer and tongue cancer surgery. Thank you very much.
Thank you, sir, for nicely describing the scenario. You mentioned about the nerve function test. You mentioned also the neck dissection protocol also. At this point, I would like to ask Dr. Hassan Kabir, would you like to say something on what sir made comment on regarding nerve examination? I think the nerve assessment, particularly of hypoglossal nerve, and also regarding the neck, and also the justification of flap, whether it was consent or not. Regarding this, do you have anything to say? Please speak.
So, thank you, sir. During clinical examination, we checked the nerve function, whether the lesion involved any nerve or not. We did all kinds of movement, and we requested the patient to do all kinds of movement like protrusion, retrusion, side-to-side movement. But the patient was quite good in all those functions. The nerve functions were intact. So we believe that the lingual or hypoglossal nerve was not involved in the within the lesion. And patient also, about the taste sensation, patient also enjoys that all the tastes. So I think all the nerves were quite intact. We thought also in the postoperative histopathology also, all the nerves are there was nerve involvement was not found. And about bilateral neck dissection, yes, sir, as the lesion was not a huge one, like the diameter is clinically you can see a 2 by 2 centimeter defect. The lesion was not that big, and also the lesion is not involved the floor of the mouth. So yes, you are right that we might be little conservative to not to do the bilateral neck dissection, but as the lymph node that we found palpable was the jugulo-digastric one, the jugulo-digastric. So we just go for the opposite side, just for the curative intent. Maybe we could have observed the patient for whether there is any neck metastasis on the left side or not, and we can do that later on. And there are so many controversies like whether to do the neck dissection in N0 neck or not. But in most of the cases, we also go for a elective neck dissection in the N0 cases. That can be in this same in this scenario also. Now we found a level 2 lymph node in MRI. We found a positive palpable lymph node in MRI, which might be metastatic. So we just go for the contralateral side neck dissection to be sure that we are doing.
You have another option for FNAC of the palpable lymph node, whether it is FNAC or the palpable lymph node, whether it is metastatic or not.
Yes, we had that option, but we didn't opt for that.
No, I didn't comment regarding use case, but as a whole, assessment for the oral cancer and tongue cancer, I say about that.
Yes, sir. Rightly said you are. And also we can perform a non-invasive investigation like a simple ultrasonogram. What can give a clue.
Ultrasound guided FNAC or ultrasonogram also, yeah. Right. It is near about 78% sensitivity in ultrasonogram also, yeah.
Yes, sir. Thank you.
Ultrasound guided FNAC is more better for assessing.
Sometimes it is told that gold standard for assessing a lymph node in case of oral.
Yeah.
Yes. Thank you, sir. Before going to our panelist, Dr. Ali Hussain, I would like to request another Ali Hussain today with us. He is the lecturer of Shoaib Sohrawardi Medical College. He is already with us. I am requesting him to, if you have any query or comments on the presentation, please place it today. Dr. Ali Hussain. Can you hear me, Ali Hussain? No, not panelist Ali Hussain, lecturer Ali Hussain. Both the same name, that's why confusion arising. I'm requesting Dr. Ali Hussain Talukdar, lecturer, Shoaib Sohrawardi Medical College. Can you hear me? Okay, I think he's not in connection right now. Then we can call him later. So I'm now going to Dr. Ali Hussain, Associate Professor, Chittagong Medical, Chattogram International Dental College. As we know, surgery alone is not the completion of the treatment in case of oral malignancy. We have to plan for further adjuvant radiation therapy or chemotherapy, or even sometimes new adjuvant also. In this regard, I would like to hear something from Dr. Ali Hussain, please.
Thank you, Dr. Iqbal. Respected chairperson, learned panel experts, and the speakers. It was a wonderful presentation.
Special thanks to Amor to organize such an exclusive webinar program related to oral cancer. Respected chairperson, respected panel of experts, moderator, my teacher, Dr. Sarinur Rahman,
can you hear me?
Other teacher, my colleague, and the presenter, Dr. Hassan Kubir. Yes, I'm hearing. Yes, sir. Can you hear? Can you hear me, sir?
Yes.
Yes, I can hear you.
Ali Hussain Talukdar, we cannot hear you properly.
Can you hear me, sir?
It's not properly. Sounds are broken.
Hello?
Yes, I can hear you.
Okay. Right now you're okay. Please.
Hello?
Okay, proceed. Ali Hussain Talukdar.
Can you hear me, sir?
Yeah.
Yes, we can hear you.
Yes, sir. I can hear you.
Okay, then proceed, please.
Sir, my query is Dr. Hassan Kabir presented this case and the surgery and the reconstruction. I think it was up to mark. T2 oral carcinoma, which is deeply infiltrated occurs through the hybrossus muscle. And in that case, sometimes patient can intraoral wound ablation. In that case, how can we that type of recurrence? My query to the panel of experts, and thank you, sir.
Okay, thank you. I think I could not hear properly. Any one of our panel expert, could you hear, please? Let us.
No, his question is not clear. Whether what is his question is not clear to me.
Just I heard only one thing. He told about the involvement of hyoglossus muscle.
Hyoglossus muscle.
And Dr. Iqbal,
yes,
it's better to give him time later on. Dr. Ali Hussain from Chittagong was started speaking. That's why it's better. It's better to.
Okay, right now we are skipping his queries.
You request Ali Hussain from Talukdar to come up later on.
Okay, Dr. Ali Hussain Talukdar, please, we will answer your question later on. Dr. Ali Hussain, I'm sorry, there are some communication problem at this moment. Please continue now.
So as we know that carcinoma of tongue has a very unique feature, as it usually spread to the ipsilateral node, with the possibility of skip metastasis and the contralateral spread. Dr. Hassan Kabir has rightly pointed out that on that point is that on MRI, the lesion was moving towards the midline. So in that case, there are so many literature and article has shown that there are chances of contralateral involvement by 5 to 10% nodal involvement. So as he has planned, ipsilateral and contralateral or bilateral dissection, as in my point of view, he was right in his treatment plan. As we know that the carcinoma of the tongue, the standard of care treatment is preferred method is the surgery. Other than surgery, there are two other options that also discussed in the literature about the neoadjuvant chemotherapy and the adjuvant therapy. Neoadjuvant chemotherapy is basically reserved for the unresectable disease or in any N3 positive NAC or resectable T4B disease. And induction chemotherapy or neoadjuvant chemotherapy does not improve the overall survival, but it can decrease the aggressiveness of the disease and can downstage the unresectable disease to the resectable disease. And it also helps in the organ preservation. So in this case, as the disease was staged as T4 and 1, so this patient was not indicated for neoadjuvant therapy. So the primary treatment was the surgical resection and followed by adjuvant chemoradiation. He was sent for chemoradiation, but I was not sure in his the surgical specimen. He did not, from Dr. Hassan Kabir, I was not clear that whether the specimen had any positive margin or there was any the lymph node, the involved node has any extracapsular extension, because when you plan for the adjuvant therapy or chemoradiation adjuvant therapy, there is an indication is that you should have a positive margin or close margin, or you can have the extracapsular extension, or if there is multi-nodal involvement. So I was not sure whether this specimen has got these features. So otherwise, this stage, stage 4, T4 and 1 and 0, is actually indicated for adjuvant radiotherapy, in my opinion. Thank you.
Thank you very much. I've seen another person, Dr. Iqbal Hussain, lecturer at Chittagong Medical College. Dr. Iqbal Hussain, can you hear me?
Yes, sir. I can hear you.
Okay. Welcome to our session today. Please, if you have query or any comments regarding the presentation, place your comments.
Assalamu alaikum, all of my respected teachers and everyone on live. Thank you, moderator Dr. Masudur Rahman Iqbal sir, for giving me opportunity to ask question. My question is regarding this case to Dr. K. Mahasan Kabir sir, that regarding this case, your treatment plan was wide local excision of the lesion with bilateral neck dissection up to level 4, followed by radial arm free flap. My question is, according to primary site, that would you consider in this regarding this case instead of wide local excision compartmental resection approach, and if so, what is the justification of compartmental resection regarding tongue cancer? Okay, thank you.
Okay, thank you, Dr. Iqbal Hussain. I would rather like to direct Dr. MD Waresuddin sir. Please, if you would like to make any comments on his query.
Now, what does the compartmental resection mean? It is only the tongue muscle is involvement over here, not the floor of the mouth and other masticatory space or other things. That's why it is a protocol to wide excision with 1 centimeter healthy margin and then reconstruction. It is not necessary to compartmental. Which compartment you will include in this respect?
Okay, thank you, sir.
Now, anything, Dr. Kabir? Will you add something?
Thank you, sir. I just going back to Dr.
Iqbal.
Dr. Hossain sir, Ali Hossain sir. He made a question about whether about the adjuvant therapy. All the margins were clear, except in histopathology report we found in one margin, the ventral margin, and the lesion was a little close, 5 millimeter. So we can 5 millimeter, within 5 millimeter. That is the reason we just opted for the neoadjuvant chemo radiotherapy, as a less than 5 is we can say the close margin. Now we are a little bit confused. We are not sure, because in most of the cases we found that in the ventral surface or the undersurface of the tongue, after resection, the resection margin gets gets shrinked, and in most of the sometimes we found that give us result, the margin was closed. But clinically, when we did the resection, we still believe that the lesion was far from the healthy margin was far from. We take enough healthy margin. But as the report says that within a 5 millimeter, the close margin, we opted for the neoadjuvant chemotherapy. And as another thing was grading of the cancer, as it was a moderately differentiated squamous cell carcinoma, we also wanted to go for chemoradiotherapy. Thank you. And
Dr. Iqbal, may I add something? Dr.
Yes,
Iqbal, may I add something?
Yes, sir.
Now, in case of these things, whenever you will do the frozen section biopsy, and after that dissected margin biopsy, dissected specimen biopsy, if the both shows that there's no positive margin, or positive margin or near to positive margin, in that case, you can observe and follow up without radiotherapy and chemotherapy. You can observe the patient without radiotherapy and chemotherapy. This is one of the protocols can be you can add.
Yes, could be a better option, but due to some constraint on corona pandemic situation, he did not go for that.
No, not that case, not only that case, but other things. If they are necking is N0 positive, no positive margin in frozen section, no positive margin in dissected specimen, then you can follow up. You can follow up the patient and observe the patient without radiotherapy.
Dr. Ali Hussain has nicely described the things when to refer the patient for adjuvant therapy, as he said, if the specimen have a positive margin, or the specimen have a positive node, or the extracancerous spread if found in the specimen.
Yes, rightly said. Yes.
Very right. Described.
Yes.
So now, as we have another case after this one, I think with the kind permission of our chairman, we can conclude the session with hearing some comments from the chairman of the session.
Thank you. There's a very good discussion on the tongue cancer. I think every aspect is discussed here. The postoperative management for radiotherapy, you can discuss what are the complications, how can you overcome this complication, the differentiate the problems that are encountered, are facing the patient. This can be discussed here, but for the time strain, I think it is not discussed here. So the question which is raised, whether the chemo radiotherapy, I think that the margin is completely clear, and there is no extracapsular spread. I think the protocol is okay. Thank you. I think we can go for the next session.
Thank you, sir.
Next speaker can invite karo.
Okay, thank you, sir. Thank you, Dr. K. Mahasan Kabir, for presenting the case before us, and I think a well discussion has been made here to make a better learning for our viewers. Now I would like to invite Dr. Fazler Abitoibur to present his case. He will present a case on gingivobuccal sulcus carcinoma.
Thank you. Thank you, Dr. Masadur Rahman. Now I'm going to present the case. So, respected chairperson, Professor Abu Muhammad Shahid, and honorable panel of experts and speakers and today's viewers, I'm going to present the case on squamous cell carcinoma of gingivobuccal sulcus. All information and photographs shared here with the consent of the patient. In particular to the patient, Mrs. Kohinoor Begum, 48 years old female. She's a housewife, came from Shaurapara of Dhaka, with the complaints of soreness in the right side of the mouth for 1 year and pain in the right side of the lower jaw for 3 months. According to the statement of the patient, she was relatively well 1 year back. Then she developed a small sore in the gingiva of buccal side of lower right molar region. Initially, the sore was very small, then it rapidly progressed and involved almost the whole lower right gingivobuccal sulcus. 3 months back, she also had started to feel pain. With the above complaints, she visited local doctors and took medicine, but the problem didn't subside. Then she came to us for better management. And in the history of patient was hypertensive and no significant patient took antihypertensive drugs regularly. Patient was married and had 2 sons and 1 daughter, and she has a history of betel quid chewing for around 30 years. And in family history, no family history of such diseases, and patient was not allergic to any specific drugs and foods, and patient was also partially immunized. On general examination, the appearance is anxious and ill-looking. Patient was conscious and cooperative with an average build, well-nourished. The patient was non-anemic and non-ecteric. And she had high blood pressure of 150 by 90 millimeter mercury. Pulse was 72 beats per minute, and respiration 80 beats per minute, and temperature is 98.4 degrees Fahrenheit. On systemic examination, most of the systems there is nothing abnormality detected, but patient was hypertensive. On local examination, in extraoral inspection, we found facial asymmetry of the right side in the form of an ill-defined swelling of the right lower cheek, and overlying skin was tensed, glossy, reddish in color with non-healing ulcer and serosanguinous discharge. On palpation, we found slightly raised temperature. Swelling was slightly tender, which was mixed in consistency, and induration beyond the swelling spatially in the upper and lower part, and skin was fixed to the underlying structure. In intraoral examination, we found the swelling ulcer in the right lower gingivobuccal sulcus. That ill-looking exophytic ulcer extending anteroposteriorly from right lower central incisor to right retromolar trigone and involved gingiva, alveolar mucosa, vestibular mucosa, approximately 6 cm into 4.5 cm. And margin was irregular, edge everted. Floor of the ulcer was covered with whitish slough, and surrounding area was glossy red and edematous. And mouth opening is 35 millimeter. On palpation, the ulcer was mildly tender, maybe due to secondary infection. Age was indurated and extends beyond the induration was also extend beyond the age, and base also indurated. The ulcer also bleeds to touch and fixed to the deeper structure. On lymph node examination, we found palpable ipsilateral multiple submandibular lymph node. Among them, largest one was about 4 centimeter in diameter, which was fixed, mildly tender, and hard in consistency. And the lymph node was fixed to the overlying skin and the underlying structure. So, in this case, our provisional diagnosis was malignant ulcer of the lower right gingivobuccal sulcus. And the differential diagnosis was squamous cell carcinoma involving the right side of lower gingivobuccal sulcus, and maybe also a deep fungal infection or squamous papilloma. So, to confirm the diagnosis, we go for some investigations, and we do incisional biopsy for histopathology, and also some investigations for staging purposes like CT scan, orthopentomogram, ultrasonogram of the whole abdomen, and other routine investigations for the fitness of GA. After getting the report of histopathology, we found that this was a case of well differentiated squamous cell carcinoma. So this is the orthopentomogram, and this is the computed tomography scan, the axial view of the lesion. This is also an axial scan. So
এবার বুঝছো আমার সাথে যে সমস্যা আছে
this is the ultrasonogram of whole abdomen. This is the ultrasonogram report, and confirmatory after getting this histopathology report, we found this is a case of well differentiated squamous cell carcinoma, and clinically TNM classification is T4A, N2A, and MX, and stage was stage 4A lesion. So our treatment plan was wide excision of the lesion with hemimandibulectomy and supraomohyoid neck dissection of the right side, and reconstruction by pectoralis major myocutaneous flap, and also adjuvant radiotherapy and or chemotherapy depending on the postoperative histopathology report. This is the preoperative photograph of the patient, extraoral photograph, and this is the skin marking for incision. This is the perioperative photograph after incision. This is also a perioperative photograph after supraomohyoid neck dissection and the wide excision of the primary side. Specimens. This is the perioperative photograph after instead of pectoralis major myocutaneous flap. closure of the defect, postoperative photograph, and after histopathology we found the pathological TNM, T4A, N2B, and MX. So for the time constraint, I made it a little bit short. So this is the case I presented. Thank you. Hello.
Thank you, Dr. Abitoimur, for presenting brilliantly. As you have shown, your case was a very advanced, moderately advanced case. I think it was a stage 4A you have presented. So now I'm requesting Dr. F.M. Ipalshoy sir to make the comments on his case as well as regarding this. We cannot hear you, sir.
Minute kora আছে কিনা?
Iqbal, you can hear, I think. Now you can hear?
Yes, sir. Yes, sir. Now it's okay.
Hello.
Yes,
you can hear now. Thank you.
Yes, yes.
যাও আমি একটু বাংলায় বলি যে এই কেসটা is a very common case in our country. If I go back in the year 1984-5, this sort of cases were very common in our country. এবং সেই সময় আমাদের রিসার্চে যেগুলি দেখা গেছে বিভিন্নভাবে যে আমাদের দেশের কতগুলি হ্যাবিটের জন্য এই ধরনের ওরাল ক্যান্সারগুলি বেশি দেখা যাচ্ছে। As Dr. Tarin has mentioned, যে tobacco leaf, tobacco betel nut, these are responsible for oral cancer. So in this case, the history was that the patient was of 48 years of age. In this 40 years of age, she has taken this betel leaf for a long time. What happens in our country, as our grandmothers and the lady in the home, they used to take the betel leaf and they used to keep it in their mouth for hours together, not only with betel leaf, with other things also, like your jorda, like your khoini, like your lemon, like your chun, etc. and etc. And when they keep it for a long time, there is a change in the mucosal tissue of the mouth. After that, after using it for few years, the white lesions that appears, but this patient, they don't bother for that. Even when there is first the ulceration in the mouth, they won't bother for that, and they used to go to the village doctors and other things. যেটা আমাদের দেশের সবচেয়ে বড় হচ্ছে যে আমি একটু আগে বলছিলাম যে early diagnosis, the better the treatment. If you can diagnose a case in an early stage, the result will be better. So এই পেশেন্টগুলি প্রথমে গ্রামের ডাক্তারের কাছে যায়, গ্রামের ডাক্তারের কাছে গিয়ে তারা বিভিন্নভাবে প্রতারিত হয় এবং বিভিন্নভাবে ম্যাল ট্রিটমেন্টের শিকার হয়, এবং যখন এই গ্রামের ডাক্তাররা এই পেশেন্টগুলিকে আর চিকিৎসা করতে পারে না, then they send it to the doctors, actually the tertiary places, এবং সেখানে আসার সময় already the time is too late. এবং এখানে যেটা দেখা যাচ্ছে যে extraoral involvement is there. When there is oral involvement, it is very difficult to treat that. When the skin is involved, এই কেসের সময় সেই ক্ষেত্রে ট্রিটমেন্টটা খুবই ইম্পর্টেন্ট এবং ট্রিটমেন্টটা খুবই ডিফিকাল্ট। এই জন্য ইউ মাস্ট হ্যাভ টু কাট এ ওয়াইড পোর্শন অফ দ্য টিস্যুস অ্যাজ ওয়েল অ্যাজ দ্য স্কিন অ্যান্ড ইউ হ্যাভ টু রিকনস্ট্রাক্ট ইট। এবং এখানে যেটা রিকনস্ট্রাকশন করা হয়েছে সেটা পেক্টোরালিস মেজর কিউটিনিয়াস ফ্লাপ দিয়ে করা হয়েছে। অ্যান্ড ইফ ইউ থিঙ্ক অফ দ্যাট, it is not easy to reconstruct a gap or a defect with pectoralis major cutaneous flap, myocutaneous flap. সুতরাং পেশেন্টের এগুলি রিকনস্ট্রাকশন করা বেশ অসুবিধা এবং তারপরে পেশেন্টের ফাংশনটা কি অবস্থা হবে যখন আমি এত বড় একটা ফ্ল্যাপ তাকে দিচ্ছি, এই ফ্ল্যাপটা ডোনার সাইডে কিভাবে থাকবে এবং সেখানে ডোনার সাইডে ঠিক মতো জোড়া লাগছে কিনা সেটাও একটা ইম্পর্টেন্ট ফ্যাক্টর। এবং আলটিমেটলি পেশেন্টের যে আমরা ম্যান্ডিবলকে কেটে ফেলে দিচ্ছে এবং ম্যান্ডিবলটা কতটুকু রিসেকশন করছে তার উপর তার মুখের অ্যাসিমেট্রিটা নির্ভর করবে। সুতরাং এইগুলিকে কনসিডার করার পরে দেন উই শুড গো ফর পোস্ট অপারেটিভ রেডিওথেরাপি অর কেমোথেরাপি। থ্যাংক ইউ।
Thank you, sir, for your nice comments and recommendations. You have rightly mentioned that these special habit, particularly in the Indian subcontinent, of betel nut chewing, betel quid, smoking, reverse smoking, the incidence of colon cancer is very high in this subcontinent, as you know. And the Zindevo-Bakkal circus is a very special one, as because, as you know, the tobacco contributes to the development of cancer, not only by its exposure, but also with its contact period. And Zindevo-Bakkal circus is one of the area where people used to keep for longer period. Some people keep it overnight, even wool or betel leaf, jodda, these things. So these sites are more common. And for has developed carcinoma, and it is called Indian oral carcinoma. The owners present choose a very typical case today for us. Right now, Dr. Mohid Alam Siddiq is with us. He registered for cellular medical. Dr. Mohid, welcome you to our session today.
Thank you.
Right, before going to our sir, I would like to ask Dr. Mohid if you have any query or comments, please place it.
Thank you very much. I am honored to present here. I am a surgeon in the field of oral and maxillofacial surgery. So I have two queries. One to Dr. Toimur. You reconstruct the defect with PMMC flap. If you would you go for the bipedal PMMC flap, or how you will cover the oral part, oral mucosa? And another question to Professor Waresuddin sir. He is a long-time teacher of mine. There is a continuous dilemma for such T4A or T4B lesions. Would you go for segmental or marginal mandibulectomy? What are the determinant factors for the marginal or segmental mandibulectomy? And how will you ensure the periosteum is involved or not involved clinically? So these are my questions to the audience, to the panelists.
First to the speaker.
So Dr. Iqbal, would you please request the expert or other participant? Somebody is disturbing. সম্ভবত বাচ্চারা ডিস্টার্ব করতেছে, ওগুলো মাইনুট করে রাখতে বলো ওদেরকে, কিছু বোঝা যাচ্ছে না।
I would like to request our panelist if please unmute your mic when you are not in speech mode, because some echo are coming and sounds is disturbing.
শুনে ইকবাল, হ্যাঁ আমার একটা সাজেশন, যারা কথা বলবে না তাদের সবাইকে মিউট করে রাখতে বলো, তাহলে খুব ডিস্টার্বেন্স হচ্ছে।
মাইকটা মিউট করে
only the speaker, যখন যার কাছে মাইক থাকবে সে শুধু
Okay, now I'm requesting Dr. Warisuddin sir, please, if you like any put any comments on his presentation and to answer your students' questions.
His presentation was very nice and operation also very nicely done. But regarding question, but he must have some other option, ALT flap or other ALT flap or other flap. And if you consider it a great sense that if you rehabilitate the patient, you can also use over here the fibula flap, two type flap, fibula and fibula flap with implant. Many things you can do, but in our country's respect, we cannot do this sort of surgery. Regarding Dr. Mohila Alam Siddiqui's question, whether we will do the marginal mandibulectomy or hemimandibulectomy or segmental mandibulectomy, it depends on the assessment. First of all, you can assess the periosteum, whether the periosteum is involved or not. Clinically, you can assess the periosteum. Periosteum a little bit distorted or inflamed. It is clinically, but on MRI imaging, it's not very much helpful for detection of the periosteum. But involvement of the bone and marginal mandibulectomy depends on the whether the lesion is a large one or a small one. If a lesion is a small one, not very much huge, and it just involve the periosteum or buccal bone, you can do the marginal mandibulectomy, not involving the socket or bone marrow. But if you have a foray lesion or other huge lesion with involvement of the marrow space and nerve canal, you must have marginal mandibulectomy, that is segmental mandibulectomy or hemimandibulectomy. And assessment should done by enhanced or contrast CT scan or bony window CT scan with the reconstruction. Anything else? Yes.
Thank you, sir. Thank you, sir. As the question arose regarding Dr. Mahul, would you like to add anything?
Yeah.
Yes, I have another question to Dr. Koimus, sir. Yes. There was a huge defect, through defect involving skin and oral mucosa. How will you reconstruct with PMMC the oral mucosa? Either did by bipedal or only face?
Yes, I'm going to tell you again before answering your question what Dr. Warisuddin sir said. And you also mentioned regarding the decision for mandibulectomy, either segmental or marginal. I think before deciding it, we have to know the pattern or mode of invasion of the mandible in case of gingivobuccal sulcus or contiguous structure, how it spread to the mandible. If we have a knowledge on it, then I think we can make better decision. So if you like, Dr. Toy would like to add anything regarding the mode of spread to the mandible, I would like to welcome you to say something on this.
Thank you for the query. In this case, we don't do the bipedical, and mucosal surface is raw here. We left it single pedal only. I think as PM is a very bulky flap, and we keep the oral mucosa raw here. it will secondary heal in the intraoral side. And regarding the invasion, tumor invasion of the mandible, there were two ways to involve. One is invasive manner pattern, and another was is erosive pattern. In case of invasive pattern, tumor directly involve the mandible by finger-like or finger-like or tumor island directly. There is no osteoclastic activity in this case. And in case of erosive pattern, there may be a broad tumor front with osteoclastic activity. And also there is a connective tissue intervening the bone and the tumor. Invasive pattern is have the most worst outcome. This is regarding the invasion of the tumor to the mandible.
ইকবাল, আমার এখানে একটা কোশ্চেন ছিল। হ্যালো,
Yes, sir. Yes,
এটা হলো, this is a big lesion, the gingivobuccal lesion crossing the skin and perforated is a big lesion with involvement of the submental glands and lymph nodes. The already lymph node is positive. Why you do the only supraoblique dissection? Why don't you choose the radical neck dissection? It should be, I think, radical neck dissection. And because you choose the pectoral major bicuspid flap, all the non-lifting structures should be removed. Whether or not. There is a very advanced scan, and because very advanced scan, there is a positive lymph node.
Yes.
You cannot do the only only indicate in case N0. You can do at least level 4 with sacrifice of sternocleidomastoid, I think. Until that, you couldn't make the bulk. You cannot control the bulk underneath the skin. কারণ তোমার পেকটিরিয়াল মেজার নেওয়ার পরে তো এমনি তো অনেক এটা মোটা হয়ে যাবে, তার সাথে স্টার্নোক্লিডোমাস্টয়েড, তোমাকে স্টার্নোক্লিডোমাস্টয়েডকে তোমাকে এমনি স্যাক্রিফাইস করতে হবে। লিশন ছোট হলো, যেহেতু পেকটিরিয়াল মেজার তুমি এটা নিছো, এখানে তুমি অ্যাকোমোডেট করতে পারবে না। তো ইকবাল, তুমি কি বলো? তুমি তো পেকটিরিয়াল মেজার তো অনেক করছো, এই ক্ষেত্রে তুমি কি বলো?
আপনার কমেন্ট ঠিকই আছে। আই থিংক মডিফাইড রেডিকাল নেক ডিসেকশন, আই মিন ফাংশনাল ডিসেকশন ওয়াজ বেটার।
আইজিবি করতে পারো, স্পাইনাল এক্সিস সেভ করতে পারো, কিন্তু স্ট্যাটিক শুড বি স্যাক্রিফাইসড।
এটা একটা। আর একটা হলো যেটা আমাদের ছিল যে ইনার লাইনিং এন্ড কভারেজ both could be achieved MFC flap by if we do a bilobe flap, but I think that
bilobe করতে পারতো অথবা স্কিন গ্রাফট করে দিতে পারো।
Defect was so big to make a bilobe flap. Yeah. So
আচ্ছা, আরেকটা যেটা বলছিল, আচ্ছা আরেকটা বলি, এখানে যেন একজন প্রশ্ন করছিল এটা বোন ইনভলভমেন্ট হয় মার্জিনাল ম্যান্ডিবুলার করবো না সেগমেন্টাল জিঞ্জিভোবাক্কাল, বাট তার মানে ফুল ডেপথ অফ দ্য ভেস্টিবুল এটা ক্রস করার পরেই বাক্কালে যায়, তাই তো? তাই বল, যেখানে ফুল ডেপথে যায় সেখানে ডেফিনেটলি অল দ্য বোনস আর ইনভলভ, সেখানে তোমাকে সেগমেন্টাল কেন? এটা হয় এটা পার্সিয়াল নাহলে হেভি করতে হবে, নাহলে আর কোনো অপশন নাই। মার্জিনাল কোনো অপশনই নেই এখানে, কারণ অ্যাডভিলাসকে ক্রস করে সে নিচে যাবে, চলে যাবে।
সেটাই
বোন থ্রু এন্ড থ্রু, অথবা এখানে তো কোনো সেগমেন্টাল হওয়ার কিছু নেই, পুরো সেগমেন্টাল হবে অথবা ম্যান্ডিবুলার।
মানে মার্জিনাল করে, কারণ মার্জিনাল শুধু করি আমরা যেখানে অ্যাডভিলাস শুধু ইনভলভ, যেখানে অ্যাডভিলাস শুধু ইনভলভ থাকে, অ্যাডভিলাস করা যাবে না।
As a whole, it is said that if a lesion involves the paramandibular structures, then you can go for total resection. So its primary tumor is the gingivobuccal sulcus origin. So Shahid sir rightly mentioned, I think.
তুমি gingivobuccal, you can strip off the lesion from the ম্যান্ডিবল, তুমি তো এটাকে পেরিস্টাল এরিয়াতে উঠাতে পারবে না, তো উঠে তো ছড়া যাবে। এটা তোমাকে ডেফিনেটলি এটা ইনভেস্ট করুক বা না করুক তোমাকে ফেলতেই হবে, হয় সেগমেন্টাল না হলে পার্সিয়ান অথবা হেভি করতে হবে। সেটা আমার সাজেশন।
Okay, we have another guest in our appearance now, Dr. Ishati Rabban. Can you hear me, Dr. Ishati Rabban?
Yes, sir, I can.
Okay, please, if you have any query or comments regarding the presentation, you can ask to the panelist.
Thank you, all of you. Assalamu alaikum and good evening. I am very much thankful to BAMOS for giving me the chance, and I am happy to see you all, my respected teachers. Actually, Dr. Toimur presented a nice presentation. I have a query. You reconstructed the surgical defect with pectoralis major flap, but if it fails, then what are the other options or another lifeboat flap you will consider in this situation?
Thank you, Dr. Ishat. I think a very valid question he arose. Dr. Toibur, would you like to answer the question?
তো পেট্রোল মেজর ছাড়া আর কি করতে পারো?
If pectoralis major, if PM flap fails, then what are the other options or lifeboat flap you will consider in that situation?
Yeah. If PM flaps, we can DP spare, DP flap. We can. If there is also, we can do also for some of free flaps, something like LT, as it is a big cavity defect. These are the options, I think.
Yes, if you consider DP flap, if you consider DP flap, then you given the then have you preserved the pedicle? You give the conventional incision to raise the PM flap.
Yeah. For this reason, we have to go for the DP sparing incision. In that case, actually, this is a huge lesion, so I don't have any other option other than flip flap. If PM flap fails here, I have to go for.
Okay.
না, তুমি কোশ্চেনটা বুঝছো? তুমি কোন কারণে পেট্রোল মেজর if it is failed, তাহলে ডিপি যে নিবা, ডিপির অপশন রাখার জন্য একটা ডিজাইন অফ দ্য ফ্ল্যাপ এটা আগে থেকে ঠিক করে
ডিজাইন অফ দ্য ফ্ল্যাপ, জি স্যার, ডিজাইন অফ দ্য ফ্ল্যাপ ইজ ভেরি মাচ ইম্পর্টেন্ট।
ডিজাইনটা ঠিক করে রাখতে হবে।
হ্যাঁ, এটা কোন কারণে পেট্রোল মেজর ফেল হলো তাহলে এটা একটা অপশন। আর এটা as because the patient is female, তোমাকে you can avoid petrous major, ALT নিতে পারো, ঠিক আছে?
Yeah.
It's an option.
Thank you.
I will add one thing. Dr. Toimur said the DP preserving incision. We can
incision. Yeah.
What
right.
Ishat was directing towards us.
I wanted to know that, sir. Yeah. I wanted to know that if we consider DP flap as a lifeboat flap, then I have to make a different incision to preserve the pedicle of DP flap.
Yeah, DP
but if we okay. If we make a conventional incision, when we actually we are using this conventional incision during raising raising PM flap. But if we consider DP flap is the lifeboat, then we have to make another flap incision design.
Yes. Yeah. Very rightly said. Before designing the incision of the PM flap, we have to consider that this flap may fail, and I have to keep the option of taking DP flap if it fails.
Later on, yeah.
Later on. This is one consideration.
Then incision design, what will be the incision design?
সেটা তোমার করতে হলে তোমাকে টেক্সটবুক করতে হবে। এটা জাস্ট অল্টারনেটিভ হলো ডিপি। এখন তুমি আগে দেখা যাচ্ছে এটা জাস্ট বলা হলো ডিপি ইজ দ্য অল্টারনেটিভ। তোমাকে ডিজাইনটা এমন ভাবে নিতে হবে ওটা নেওয়া যায়।
Okay, no problem, Dr. Ishar. Incision design will be such, you just design your DP and put your incision
Yes, sir.
away from that design. Just lateral to
Yes.
it. Make it just
Okay, sir. Thank you. I wanted to hear this, sir. Yes, sir. I wanted to hear this, sir.
Okay, thank you.
In this situation, flap design is different.
Design is different, and just put the incision lateral.
Incision is different. Incision is different.
Definitely. Number one consideration. Number two,
okay.
As the defect is very much near to the forehead, you can consider the forehead flap as a live board flap also. Not only DP.
As a live board flap কিন্তু not the DP. Live board flap একমাত্র frontalis muscle.
Forehead flap is
forehead flap is the live board. আচ্ছা তুমি যেটা বলছো ডিজাইনটা হলো আর্মের দিকে ল্যাটারালি চলে যাওয়া, আর্মের দিকে ল্যাটারালি চলে গেছে।
ওকে স্যার, আর্মের দিকে ল্যাটারালি চলে যেতে হবে। জি স্যার, জাস্ট আই ওয়ান্ট টু হেড দ্যাট স্যার।
Yes, just
because you have to preserve the vascularity of the
I got my answer.
Okay, thank you, Dr. Ishar.
You have to preserve the vascularity of the DP flap. That's why you have to go laterally. Yeah.
Yes, sir. Yes, sir. To preserve the vascularity or pedicle of the DP flap.
Vascularity of the.
Thank you very much. Thank you very much, sir.
Okay.
Good question. Thank you.
You have two other options also.
Thank you. Thank you very much.
Latissimus dorsi flap. As because the patient is female, latissimus dorsi as a primary consideration also a good flap. Because we have to we have to avoid PM flap in female. In that case, latissimus dorsi is good flap. And as a last resort, you can consider forehead flap. As because it creates an ugly cosmetic defect. So it should be considered the last stage.
Last choice.
Last choice, yes, sir. And if possible, then you can consider for free flap. And LT defect would be a good option because there is a huge defect. So you have to fill up the bulk also. So LT flap is a good option.
And also patient was being radiated later on.
এটা বাল তো রেডিয়েট ফোরআর্ম দিয়ে এটা হবে না, এটা বাল তো এটা হলো
not the radial flap, radiated. Patient was being radiated, that's why you have to consider the free flap later on. After failure of the primary flap.
Okay, now
এখানে ব্যাপার আছে পেট্রোয়েড মেজর তখনই ফেল হয় যদি এটা এক্সটেনশন যদি ক্রসিং যে জ্যাগোমেট্রিক কাজ টু বিগ গ্যাপ, সেখানে পিএম কে আনা যায় না, তখন দেখা যায় পিএম উইল বি ফেলিয়ার। হ্যাঁ, সেখানে ফোরহেড ফ্ল্যাপ পরে আনতে হয় অথবা ফ্রি ফ্ল্যাপ আনতে হয়, তখন কনসিডারেশন। ঠিক আছে।
Okay, thank you, sir. Now I am moving to Dr. Tarin Rahman, madam. Thank you, Dr. Tarin Rahman, madam. Madam, please would you please tell us about how the prognosis of the oral cancer can be assessed or presumed before making a decision? The prognosis, with what factors affects the prognosis?
আপা আপনারটা মিউট করা নাই, মিউট করা আছে, ঠিক করে দেন।
আনমিউট করতে হবে, একটু
আনমিউট করতে হবে।
প্রগনোসিস আমাদের কিছু ক্লিনিকোপ্যাথোলজিক্যাল, ধন্যবাদ ডক্টর ইকবাল আমাকে আবার সুযোগ দেওয়ার জন্য। আমাদের প্রগনোসিস আমাদের কিছু ক্লিনিকোপ্যাথোলজিক্যাল ফ্যাক্টরের উপরে আমাদের ডিপেন্ড করে, যেটা আমাদের রিকারেন্স এবং সার্ভাইভাল, ওভারঅল সার্ভাইভাল, আমাদের ডিজিজ ফ্রি সার্ভাইভাল, সমস্ত কিছু আমাদের ডিপেন্ড করে আমাদের কিছু ক্লিনিকোপ্যাথোলজিক্যাল ফ্যাক্টরের উপরে। যে আমাদের ক্লিনিক্যাল ফ্যাক্টর গুলা আমাদের আমাদের স্টেজিং, আমাদের এইজ অফ দ্য পেশেন্ট, আমাদের স্টেজিং, ক্লিনিক্যাল স্টেজিং আমাদের আসবে, আমাদের অবশ্যই পেশেন্টের গ্রেডিং করে এবং গ্রেড যত বাড়বে আমাদের খুব সম্ভবত আমাদের হাসান কবির সে তার পেশেন্টের বেলায় বলেছে যে কেন সে কেমোথেরাপির কথা বলেছে যে তার গ্রেড বেশি ছিল, এবং আমাদের হিস্টোলজিক্যাল রিস্ক ফ্যাক্টর আছে। আমরা ক্লিনিক্যাল স্টেজিং বললাম, হিস্টোলজিক্যাল রিস্ক ফ্যাক্টরের মধ্যে আমাদের আসবে স্টেটাস অফ দ্য মার্জিন, ডেপথ অফ ইনভেশন আমাদের, তারপরে পেরিনিউরাল ইনভেশন, লিম্ফোভাস্কুলার ইনভেশন, এবং টিউমার পোস্ট যে আমাদের রিলেশন অ্যাট দ্য ফেজ, অ্যাট দ্য ইন্টারফেস অফ টিউমার অ্যান্ড পোস্ট, এখানে আমাদের ডিফেন্সিভ মেকানিজম অফ লিম্ফোসাইট আমাদের কাউন্ট কিরকম ছিল সেটার উপরেও আমাদের ডিপেন্ড করবে। কাজে দিস আর দ্য ফ্যাক্টরস, আমাদের ক্লিনিকোপ্যাথোলজিক্যাল ফ্যাক্টরস ডিটারমাইন আমাদের প্রগনোসিস অফ দ্য ডিজিজ। আমাদের এখানে কি হয়, আমাদের এখানে আমাদের পরিপ্রেক্ষিতে একটু কথা বলি। আমাদের পেশেন্ট গুলো আসে অনেক লেট স্টেজে, ম্যাক্সিমাম মোস্ট অফ দ্য পেশেন্টস আমাদের আসে স্টেজ 4 এ, এবং আমাদের যে দুটো পেশেন্ট, আমাদের দুজন অ্যাসিস্ট্যান্ট প্রফেসর সাহেব, একজন হাসান কবির সাহেব, একজন ফজলে রাব্বি তৈমুর সাহেব দেখালেন অ্যাডভান্স স্টেজ, দুটাই অ্যাডভান্স স্টেজে। কাজে আমাদের ম্যাক্সিমামই আসে স্টেজ 4 এ। আমাদের মোস্ট অফ দ্য পেশেন্ট আমাদের দেখা যায় যে 75% অফ দ্য কেসেস আমাদের চলে আসে স্টেজ 4 এ। কাজে এই যে আমাদের স্টেজ 4 এ পেশেন্টরা আসছে, এদের তো আমরা কখনোই গুড সার্ভাইভাল এক্সপেক্ট করতে পারি না। 5 ইয়ার সার্ভাইভাল আমাদের যেখানে ডেভেলপ কান্ট্রিতে 57%, আমরা এখনো 5 ইয়ার ওভারঅল সার্ভাইভাল রেট 57%। আমাদের সেখানে আমরা এখনো আমাদের সেন্টারে আমরা এটা অ্যানালাইসিস করি নাই যে আমাদের কত পার্সেন্ট। তারপরেও আমাদের কিছু আরো কিছু সমস্যা আছে যেগুলা আমরা আমাদের এই দুইটা কেস যে ওনারা প্রেজেন্ট করলেন সেখানে আমাদের রিফ্লেকশন হয়েছে। সেটা হলো যে আমাদের যখন আমরা আমাদের একজন প্যানেলিস্ট গতকাল বলছিলেন যে আমাদের কম্প্রিহেন্সিভ ট্রিটমেন্ট প্ল্যানিং এর ব্যাপারে একটা বোর্ড অবশ্যই আমাদের ট্রিটমেন্ট দেওয়ার আগে আমাদের হওয়া উচিত। সেখানে আমাদের যেমন আমাদের সার্জিক্যাল অনকোলজিস্ট, মেডিকেল অনকোলজিস্ট, প্যাথোলজিস্ট, আমাদের স্পিচ থেরাপিস্ট, ফিজিওথেরাপিস্ট, আমাদের একজন সাইকিয়াট্রিস্ট, ক্লিনিক্যাল সাইকোলজিস্ট আমাদের থাকা, সবাই মিলে সম্মিলিতভাবে একটা ডিসিশন নেওয়ার কথা। কিন্তু আমরা সেটা আমরা পারি না। আমাদের নিজেদেরকে একটা এককভাবে ডিসিশন নিতে হয় যে আমরা সার্জারিটা আমরা কিভাবে করবো, আমরা প্যাথোলজিস্ট পাই না, এবং পরবর্তী চিকিৎসার জন্য যেহেতু আমরা এখানে আমাদের বোর্ড তৈরি করতে পারি না, আমরা বোর্ড বসাতে পারি না, আমরা মহাখালী ক্যান্সার হাসপাতালে আমরা রেফার করি, যেটা সরকারি লেভেলে আমাদের সরকারি হাসপাতাল থেকে, সেখানে আমাদের করতে হবে। ঢাকা মেডিকেল কলেজে পেশেন্ট যদি বাইরের হয়, বরিশাল, বগুড়া, আমাদের ময়মনসিংহ মেডিকেল কলেজ, ওখানে ওই এলাকায় যারা থাকে তাদেরকে আমাদের রেফার করতে হয়। কিন্তু আনফরচুনেটলি এসব একমাত্র এখন রেডিওথেরাপি অপশন শুধুমাত্র মহাখালী ক্যান্সার হসপিটালে আমি যতদূর জানি আমাদের ছিল। এবং একটা প্রশ্ন আসছে ওয়াই কেমোথেরাপি। এখানে কি হয় যে আমাদের যেহেতু পেশেন্ট লোড, আমাদের এখানে পেশেন্ট লোড আমরা যেখানে আমাদের ডেভেলপ কান্ট্রিতে কমার্শিয়াল কার্সিনোমার আমাদের ইনসিডেন্স হলো 2% অফ দ্য হোল বডি ক্যান্সার। আর আমাদের এখানে আমাদের এই রিজনে, এই সাবকন্টিনেন্টে রাফলি 40% অফ দ্য হোল বডি ক্যান্সার। তার মানে আমরা এখানে বুঝতেই পারছি যে আমাদের লোডটা কত বেশি। আমাদের সরকার, গভর্নমেন্ট এটা আমাদেরকে প্রোভাইড করতে পারে না এডজুভেন্ট থেরাপির জন্য আমাদের সব পেশেন্টকে। কাজে সেই পেশেন্টদেরকে ওয়েটিং এ রাখার জন্য বা তাদের যাতে ডিজিজটা প্রোগ্রেস না করে আমাদের আমরা সার্জারি করে দেওয়ার পরে সেখানে তাদেরকে তারা সেজন্য কেমোথেরাপি দিয়ে দেয়। প্রতিটা পেশেন্টকে প্রায় কেমোথেরাপি দেয়, এবং এটার ফলাফল কিন্তু খুব ভয়ঙ্কর ফলাফল আমরা যে দেখছি। যদিও আমরা এটা এখনো আমাদের এটার ইফেক্ট আমরা এখনো অ্যানালাইসিস করতে পারি নাই, সেজন্য আমরা এখন এটার রেজাল্টকে এত কনফার্ম হয়ে এত শিওরে আমরা বলতে পারছি না। কিন্তু আমাদের যে এক্সপেরিয়েন্স সেটা আমরা বলছি। আর আরেকটা ব্যাপার যে এটা নিয়ে প্রশ্ন আসলো যে ওয়াই বাইল্যাটারাল নেক ডিসেকশন। হ্যাঁ, এটা তো আমাদের কিছু প্রোটোকল থাকবে। সেখানে আমরা N0-তে আমরা সবসময় আমরা নেক ডিসেকশন আমরা প্রেফার করি। এটা কেন? ফর আওয়ার কান্ট্রি, আমাদের সেন্টার, আমাদের দেশের জন্য। তার কারণ আমাদের পেশেন্ট গুলা কি হয়, লস্ট হয়ে যায়, তারা আর পরবর্তীতে পেশেন্টরা ফলো আপে সহজে আসতে চায় না। এবং এই যে অ্যাডজুভেন্ট থেরাপি, এটাও পেশেন্টের সোশিও ইকোনমিক কন্ডিশন, লো সোশিও ইকোনমিক কন্ডিশনের পেশেন্টদের, আমি আগেও এটিওলজি বলতে যেয়ে বলেছি, শুধুমাত্র টোব্যাকো যে একা একা কাজ করছে তা না, টোব্যাকোর সাথে অবশ্যই ম্যালনিউট্রিশনও কাজ করছে। তার কারা ম্যালনিউট্রিশ? আমাদের পোর পপুলেশন যারা, তারাই সোশিও ইকোনমিক পোর যারা, তারা এখন তারা পরবর্তী থেরাপিটা যেটা, তারা এডজুভেন্ট থেরাপি যদি তাদের প্রয়োজনও হয়, তখন তারা আর আমাদের পেশেন্ট এডজুভেন্ট থেরাপির জন্য যেতে পারে না, তারা এফোর্ড করতে পারে না। এই সার্জারিটা করতে যেয়ে তারা নিঃস্ব হয়ে যায়। তখন তারা পরবর্তীতে তাদের যাদের নাকি প্রয়োজন, আমাদের, আমি বলছি হিস্টোলজি, আমাদের কিছু হিস্টোলজিক্যাল রিস্ক ফ্যাক্টর যেগুলো আছে, প্যাথোলজিক্যাল রিস্ক ফ্যাক্টর যেগুলো আমাদের পেরিনিউরাল ইনফেকশন, লিম্ফোভাস্কুলার ইনভেশন, বোন ইনভেশন, আমাদের ডেপথ অফ ইনভেশন যখন বেশি থাকে, আমাদের মার্জিন পজিটিভ থাকে, সার্টেনলি তাদের এডজুভেন্ট থেরাপি তাদের লাগবে। বা আমাদের এক্সট্রানোডাল আমাদের ইনভলভমেন্ট যদি থাকে, বা লিফ নোড যখন ইনভলভ হয়, তখন তারা রেডিওথেরাপি দিবে। তো পেশেন্ট কিন্তু এফোর্ড করতে পারে না। এই যে পেশেন্ট এডজুভেন্ট থেরাপি তারা যাদের প্রয়োজন তারা দিতে পারে না, তখন এটাও কিন্তু আমাদের একটা ব্যাড প্রগনোসিসের কারণ। যারা এডজুভেন্ট থেরাপি যাদের প্রয়োজন তারা দিতে পারছে না। এটা হলো আমাদের সিনারিও, আমাদের দেশের সিনারিও। কাজেই এটা আমার বলতে বলা হয় নাই, তবু আমি বলি, যদি স্যার, আমার শ্রদ্ধেয় স্যার, উনি অলরেডি বলেছেন যে প্রিভেনশন ইজ বেটার দেন কিওর। আমাদের প্রিভেনশনটা দিকে আমাদের অনেক বেশি জোর দিতে হবে। আমরা দুইটা কেসেই আমরা দেখেছি যে আমাদের পেশেন্টরা 12 ঘাটে ঘুরে, স্যারও এটা মেনশন করেছে, তারপরে আমাদের কাছে আসে। তারা বিভিন্ন ডাক্তার, গ্রাম্য ডাক্তারের কাছে হোমিওপ্যাথিক ট্রিটমেন্ট নিয়ে আমাদের তারপরে এখানে আসে। এটাতে এই যে আমাদের কি রিফ্লেকশন হচ্ছে, আমাদের মোটিভেটেড পার্সন, আমাদের স্কিল পার্সোনাল রুট লেভেলে আমাদের নাই, এবং আমাদের যে রেফারেল সিস্টেম এটাও আমাদের খুব পোর। কাজে আমাদেরকে এখন সচেতন হওয়া দরকার, আমাদের সকলের একসাথে। আমরা যে প্ল্যাটফর্ম থেকে আজকে এই ওয়েবিনারটা করছি, বামোস, এবং আরো আমাদের ওরাল ক্যান্সার ফাউন্ডেশন আছে, ওরাল ক্যান্সার সোসাইটি আছে, বিভিন্ন ফোরামে কাজ করছে। আমাদের সকলকে এখন অনেক বেশি কনসেন্ট্রেট করা দরকার আমাদের পেশেন্টকে, আমাদের আর্লি ডিটেকশন এবং আমাদের প্রিভেনশনের দিকে আমাদের অনেক বেশি আমাদের মনোযোগী হওয়া দরকার। যা হলে যা আমাদের যে হেলথ সিস্টেমের উপরে যে বার্ডেনটা আসছে সেটাও কমবে এবং আমাদের লোকরাও সুস্থ থাকবে। আমরা এই যে অ্যান্টি টোব্যাকো মোটিভেশন, এটা কিন্তু খুবই সোজা। এটা আমরা ইচ্ছা করলে আমরা এই কাজগুলো আমরা করতে পারি। শুধু গভর্নমেন্ট কেন, আমরা প্রত্যেকেই কিন্তু আমাদের নিজের জায়গা থেকে আমরা করতে পারি। একজন ডেন্টাল সার্জন আমাদের যারা থানা হেলথ কমপ্লেক্সে কাজ করে, তারা তো আমাদেরই স্টুডেন্টরা সেখানে যায়। আমরা যখন তারা ফাইনাল ইয়ারে আসে বা সেকেন্ড ইয়ারে যখন তারা আমাদের এপিডেমিওলজি তারা পড়ে, যখন তারা প্রিভেন্টিভ ডিজিজ পড়ে, তখনই কিন্তু তাদেরকে আমরা এই জিনিসগুলো শেখাতে পারি এবং তাদের সেই স্যার আরেকটা বলছেন ডায়াগনস্টিক স্কিল আমরা তৈরি করে দিতে পারি, যাতে তারা আমাদের গ্রাম লেভেলে উপজেলা হেলথ কমপ্লেক্সে এটাকে ডিটেক্ট করতে পারে এবং তারা যখন আর্লি স্টেজ একটা বায়োপসি নেওয়ার জন্য তারা যদি না পারে, তারা কিন্তু জেলা পর্যায়ে সেটা পাঠাতে পারে। তাহলে কিন্তু আমাদের টারশিয়ারি লেভেলে বা ঢাকার উপরে পেশেন্টের এত বার্ডেন, আমাদের হসপিটালের উপরে বার্ডেন পড়ে না, এবং আমাদের পেশেন্টের যে এত অর্থনৈতিক তাদের যে একটা বার্ডেন চলে আসে তাদের উপরে, যে তাদের এত পয়সা খরচ হয় না, তারা নিজেরাও অনেক কম খরচে তাদের ডিটেকশন করতে পারে, প্রিভেনশন করতে পারে আর্লি স্টেজে। আমাদের পেশেন্টের সার্জারি শুধু একমাত্র লাগবে, আমাদের অ্যাডজুভেন্ট থেরাপির দরকার হবে না। সেখানে তাদের অর্থনৈতিক সাশ্রয় হবে, এখানে তাদের যে প্রগনোসিসও ভালো হবে, আমাদের নিজেদের ভালো, আমাদের দেশের জন্য, সরকারের জন্য সেটা অনেক বেশি মঙ্গলজনক হবে। ধন্যবাদ আবার সবাইকে। আমাকে এখানে সুযোগ দেওয়ার জন্য, কিছু বলার জন্য, এবং রাজ টিভিকে ধন্যবাদ যে তারা যে আমাদের কিছু সুযোগ করে দিয়েছে। আমাদের যে টিপিক্যাল কেসগুলা, যে অ্যাডভান্স স্টেজে কেসগুলা আমরা ডিল করি, এবং আস্তে আস্তে যে আমাদের হাঁটি হাঁটি পা পা করে আমাদের সেন্টার গুলা আগাচ্ছে। আগে আমরা এক সময় আমরা কোনো রিকনস্ট্রাকশন পারতাম না, তখন আমাদের পেশেন্ট গুলাকে ছেড়ে দিতে হতো। কিন্তু আস্তে আস্তে প্রথমে আমাদের মেডিকেল ফ্ল্যাব বা লোকাল ফ্ল্যাব দিয়ে কাজ করা শুরু হলো, সেটা এখন এস্টাবলিশ হয়েছে। তারপরে এখন আবার ফ্রি ফ্ল্যাপও ওরা করছে, যে দুটা কেসে এটারই একটা রিফ্লেকশন আসছে। এবং একটা সময় অবশ্যই ইনশাআল্লাহ আমাদের হবে যখন আমরা একই ছাদের নিচে এই কম্প্রিহেন্সিভ ট্রিটমেন্টটা আমরা দিতে পারবো, যখন এটাও আমাদের একটা সুবিধা হবে। এবং আশা করি যে আমাদের পেশেন্টকে আর্লি ডিটেকশন, মোটিভেশন আমাদের এত বেশি হবে যে সব পেশেন্ট টোবাকো খাওয়া বা তাদের টোবাকো কনজাম্পশন, বেটল কুইট, এটা পেশেন্ট পরিহার করবে এবং আমাদের দেশের জন্য একটা মঙ্গলজনক সুন্দর পরিবেশ নিয়ে আসবে। ধন্যবাদ।
Thank you, madam, for your nice comments and good hope. We think also and agree with you regarding the prognosis. These factors should be considered and these issues definitely come. And besides this, I think some other issues also important, as in oral cancer we know the lymph node metastasis is a very bad prognostic feature. As said, is a single lymph node involvement reduces the prognosis by 50%, as well as the tumor depth of invasion of the tumor. It's also plays an important impact. So I'm requesting Dr. Taimur again, if you like to say anything about the tumor thickness, in not only in your case, in case of oral cancer, how it is measured and how it affects the prognosis. Just quick comments. Before starting, Dr. Taimur, we have one guest who will ask a question to us. She's Dr. Rivi, I think. She's the daughter of our today's chairman. She will ask a question today. Please, if you can hear me, please ask the question. I think she is not in connection. Okay. Can you hear me?
That she is a dental background or medical background? Which background?
Please ask the question to Dr. Shahid sir, the chairman of today's session. He will make comments.
ও তো লিংক পাচ্ছে না, লিংক এখনো দেয় নাই।
লিংক দেয় নাই? তো স্ক্রিনে কে আছে? আমি কিন্তু স্ক্রিনটা ভালো দেখতে পাচ্ছি না। স্ক্রিনে কে আছে?
He is not beside you.
Beside, তাহলে কি আমার স্ক্রিনে দিয়ে দিব?
হ্যাঁ দিয়ে দেব।
হ্যাঁ তাহলে আমার স্ক্রিনে দিয়ে দিব। আচ্ছা নাও
দিয়ে দাও। It's better.
Okay, I'm requesting you to ask a question to our panelist.
And give her a thanks, Dr. Iqbal.
Definitely. Thank you very much for feeling that you can ask a question and participate in our session. Thanks for coming here.
আসসালামু আলাইকুম, আমি এই প্যানেলদের কাছে একটি কোয়েশ্চেন করতে যাচ্ছি। শ্রদ্ধেয় স্যার এবং ম্যাডামরা, আমার একটি কোয়েশ্চেন ছিল প্রথম কেস নিয়ে। প্রথম কেসটি ছিল স্কোয়ামাস সেল কার্সিনোমা টান। আমরা যা জানি যে স্কোয়ামাস সেল কার্সিনোমার ইউজুয়ালি যে এটিওলজিক্যাল ফ্যাক্টর গুলো থাকে, যেমন বিটল নাট চুইং, এক্সেসিভ শার্পনেস টিপস, কিছু ভাইরাস, এগুলোর কোনোটাই প্রথম কেসে প্রেজেন্ট ছিল না। আর আমাদের দেশে অধিকাংশ নারী আয়রন ডেফিসিয়েন্সি অ্যানিমিয়াতে ভুগেন। সেখান থেকে পামার-ভিনসন সিনড্রোম যদি ডেভেলপ করে, আর পামার-ভিনসন সিনড্রোম থেকে মিউকোজাল অ্যাট্রফি হয়ে আলটিমেটলি স্কোয়ামাস সেল কার্সিনোমা অফ দ্য টাং ডেভেলপ করতে পারে। সেক্ষেত্রে ওরাল ক্যান্সারের ক্ষেত্রে আমাদের কি পামার-বেনসন সিনড্রোম নিয়ে আরো বেশি মানে কনসার্নড হওয়া কতখানি দরকার, আর এটাকে কতখানি কনসিডারেশনে আনা উচিত?
I think Dr. Waresuddin sir, please, if you respond to the question.
Thank you. I don't know her name. Very nice question, but as because we have several etiological factors in oral squamous cell carcinoma, as Dr. Tarin, tongue cancer, and Dr. Tarin mentioned several etiological factors, but Palmer-Bishop Simpson didn't mention. It is one of the cause maybe, but we in our country we don't have any study regarding the Palmer-Bishop syndrome, but we have a study in HPV virus. But we can later on we can get importance or emphasis, get emphasis over this. Thank you for your nice question. And iron deficiency anemia is also very important in case of oral squamous cell carcinoma in the regarding management protocol of squamous cell carcinoma. That's why thank you very much for your nice question.
Thank you.
Thank you, sir.
Thank you.
Coming back to Dr. Toimur, what you are asked regarding the depth of invasion.
Tumor thickness and depth of invasion present very crucial. As you know, a new AGCC animal in 2008, they add depth of invasion. They add depth of invasion in the tumor TNM classification, primary tumor. Tumor thickness is the whole thickness of the lesion, that is from the ulcer surface, the deepest point of the invasion. And there is a little difference in the depth of invasion. Depth of invasion is the measurement taken from the basement membrane of the normal mucosa to the deepest point of invasion. Both of these related with the occult prognosis. This is a very important prognostic factor. In case of it may increase the chance of occult metastasis and also impact the overall survival rate. As when tumor thickness is less than 2 millimeter, then chance of survival is more than 95%. And when it is more than 5%, it is reduced to 85%. And chance of occult metastasis is also increased around more than 60%. When it is more than 9 millimeter, in case of depth of invasion, so associated with 65% chance of occult metastasis. So you all know that this ultimately affects the overall survival rate. So these are about the tumor thickness and depth of invasion. Yes, please.
Yes, thank you, Dr. Toimur. You have rightly mentioned everything regarding the depth of invasion. And definitely it has a very important value as we see in new AGCC 8th edition TNM classification. They mentioned in every T stage they related it with the depth of tumor invasion ranging from T1 to T4. So definitely it plays an important role. Thank you, Dr. Toimur. As you know, our session today is sponsored by Mundi Pharma Bangladesh Limited. And on behalf of Mundi Pharma, we are thankful to them, and Dr. Shah Miran, Dr. Shah Miran, Manager Medical Affairs, Mundi Pharma Bangladesh Limited, is with us now. Welcome, Dr. Shah Miran.
Thank you.
I will come to you a bit later. Just before going to you, I have one more panelist to make a few comments. Dr. Mohammad Afzal, Dr. Mohammad Ali Hussain. My specific query to you: if we find the invasion of bone, say it is mandible or maxilla, whatever, then what should be the primary? What role of the radiotherapy is there in case of bone invasion, rather than surgery? If we choose the radiotherapy as the first choice, how much it is valuable?
Before I come to your question, I just want to add something with the depth of invasion and the tumor thickness. There is a landmark study done in the Tata Memorial Hospital by Pankaj Chaturvedi, by Dr. Pankaj Chaturvedi. He has mentioned that if the depth of invasion is increased more than 4 millimeter, then there is a more chances of nodal involvement, and also there is increased chances of extracapsular spread. In their study, they have found this interesting feature that the more the depth of invasion, the nodal involvement, more the extracapsular spread. And one more thing is that the measurement can be done intraoperatively by frozen section, so that if you find the more thickness of the tumor, you can go for a more neck dissection, like you can extend the supraoma height neck dissection, or you can go for modified radical neck dissection. This is their findings in their study. And the second question, I didn't get the second question, that if the bone is involved with the tumor, what should be the radiotherapy dose? Or I didn't get. Dr. Warasudin sir, can you help me the question? What was
Yes,
the question?
they asked whether if there is involvement of the bone, if there any role of radiotherapy by without surgery. This is the question.
Yes, if the patient is unfit for the surgery, there is a patient is suffering from any other comorbid disease, then you definitely you can go for a definitive radiotherapy. It's more than
only radiotherapy or chemoradiotherapy?
Chemoradiotherapy is
chemoradiation or only radiation?
Chemoradiation is dictated by the nodal involvement. If there is a nodal involvement 2B, yes, the patient can have chemoradiation. If there is no nodal involvement, if there is only bone involvement, then you can go for a 60 grays or more than 60 grays radiotherapy as a definitive treatment.
Whether it could be palliative palliative intention or curative intention.
Definitive treatment.
Yes, therapeutic intention, not the palliative intention, because patient is not having surgery, as maybe it is his preference not to have that, or patient is not medically fit for the surgery. In that case, you can go for the therapeutic definitive radiotherapy. And one more thing that I want to add in this GBS carcinoma, that he has mentioned the involvement of the skin and composite resection and composite micro reconstruction. Reconstruction. Composite reconstruction. But one important thing, the involvement of the masticatory space and the CECT before planning, CECT with puffed cheek technique, that to see the outline of the tumor and outline of the buccinator muscle. Whether, although the skin is involved, definitely buccinator is involved. But my question is that if you get the CECT with the puffed cheek technique, you can outline the tumor and you can see the sulcus very well. And the spreading of the tumor from the GBS, as you know, that it has got a very complex anatomy, it can spread to the masticated space. So in that case, if the patient has got the limited mouth opening, like 35 millimeter, am I right? It was 35 millimeter the mouth opening? Yes. As you mentioned in your clinical.
Yes.
So patient has got some kind of masticated space involvement. So
compartmental.
Yeah, the patient, as he mentioned, that he has gone for hemimandibulectomy with the disarticulation. In those cases, you can get access the masticatorial space, and you can go for the compartmental resection of the medial pterygoid muscle or masseter muscle and everything. Thank you.
Yes, thank you, Dr. Ali Hussein, for making nice comments and good recommendation regarding the involvement of masticatory space. And definitely we have for compartmental resection of the infratemporal fossa as well, as because of from gingival sulcus carcinoma rapidly involves the retromolar trigon, and they can invade the pterygoids also. Okay, thank you. Now we are almost to the end of the session. So many issues have been discussed, but definitely not all, because the issues regarding the cancer are so many. Before concluding the session, I would like to invite Dr. Shah Miran to convey his vote of thanks to our session. Dr. Shah Miran, please.
Okay, thank you. Honorable Chairperson, distinguished panelists, respected speakers, and the moderator. Assalamu alaikum and very good evening. So first, I'd like to remember the person who sacrificed their life during this pandemic situation. And I am from the Mundi Pharma Bangladesh. We are very much grateful to all of you, the frontline health workers who are giving the treatment to the patient in this tough pandemic situation. And I'd like to thank the speakers and the panelists for very brief discussion on the oral cancer. And this will definitely help the knowledge aspirant and as well as our viewers to get some ideas about the oral cancer. And from Mundi Pharma, from Betadine range of product, we have so many formulations like Betadine solution, Betadine surgical scrub, ointment that are very much important for the surgical preparation and post-surgical care. And we have also the Betadine gargle and mouthwash, which is very much effective against the COVID-19. That is already proven by so many trials that it kills the SARS-CoV-2 virus within 15 to 30 seconds of contact. And I would not take too much time because it is already 11:40 almost. So with the hope of good health to everyone, I would like to conclude my speech. Thank you, everyone.
Thank you.
Thank you.
Thank you very much, Dr. Shah Miran. We are just now near the concluding of the session. Before going to the chairman of today's session, I would like to hear a few final comments of our senior panel member, Dr. Asim Iqbal Shahid, sir.
Thank you, everybody. Thank you to the speakers and to the panelists. Within this 2.5 hours time, we have tried to discuss in all aspects of oral cancer, mainly the tongue cancer and the buccal sulcus cancer. So I think with this discussion, the audience will be benefited. So the last thing is that we should detect oral cancer as early as possible. So we should train our young doctors, young dentists, those who are working in the peripheral level, how they can detect the oral cancer very early. If they can detect the oral cancer in an early stage, they can refer it to the tertiary place, and early the treatment, better the result. We should think of it. So this much today. Thank you.
Thank you very much, sir. So we are now like to conclude the session with the final speech from the chairman of the session. Before hearing him, I would like to say to the viewers, thanks for watching the program, and being with us throughout the previous program. And BAMOS definitely will arrange such webinar sessions on the upcoming days. And I hope you will be with us for the next events also. We are looking forward. I'm giving the inviting Dr. Muhammad Awad for making his final speech. Abu Muhammad Shahid, please.
Thank you, everyone, and a precious thanks to our sponsor, Mundi Pharma, and also the broadcaster of the RAS TV. We already discussed in the different aspects of squamous cell carcinoma, clinical diagnosis, investigations, treatment protocols, and reconstructions, and post-operative therapy. And early detection is already mentioned that early detection is very important. So from the periphery where our young dental surgeons are working, they should be trained up at least for the initial diagnosis. So screening is very important, and we should take the help from dental surgeons. And another thing, this is a multidisciplinary approach. So I think it is not still started in our country, the cancer clinic.
Yes.
In foreign countries, everywhere there's a cancer clinic where the oncologists, histopathologists, microvascular surgeons, that is plastic surgeons and maxillary surgeons are involved. And they all together, they come to a decision, what would be the treatment plan. I think we can start here for the betterment of the patient and the better outcome. Thank you everyone for long time patience and participants as well as the audience. Thank you everyone. Okay. Assalamu alaikum.
Thank you everybody. Allah.
Thank you. Thank you very much and very good night to all. I am looking forward to our next sessions. Till then,
thank you.
Stay safe and good health. Thank you.
Assalamu alaikum.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our